Hi, I'm Loren Katchel from the Princess Alexandra Hospital, and I'll be discussing the utility of 18F FET PET MRI for the differentiation of post-therapy changes versus disease recurrence in brain malignancy. Brain tumours or cancers refers to a heterogeneous group of lesions arising from cells within the central nervous system and can be defined as either malignant or benign. Malignant brain tumours in general have faster growth rates and are more invasive than benign brain tumours. They tend to have a poorer prognosis as they have high incidences of residual or recurrent disease post-intervention. Malignant tumours can be further divided into two main categories, those being primary or secondary. Primary brain malignancies originating from the neuroepithelial tissue are the most common, with glioblastomas nearly accounting for 2/3 of all neuroepithelial tumours. Secondary or metastatic brain tumours are the most prevalent brain malignancies seen in adults and commonly metastasize from malignancies of the lung, breast, skin, kidney, and gastrointestinal tract. The current gold standard for evaluating brain malignancies is magnetic resonance imaging, which in general provides superior anatomical imaging and spatial resolution in comparison to other imaging modalities. However, MRI does have limitations in distinguishing tumour from non-tumour tissue in the post-surgical and radiation treatment phase. Molecular imaging with PET-CT has been viewed as a prevailing complementary tool for brain tumour imaging. Fluorine 18 fluorodeoxyglucose is the most commonly used PET radiopharmaceutical in oncology. However, because of the brain's high glucose metabolism, differentiation of physical processes from malignancy can be problematic. In recent years, there has been an increased interest in the use of radio-labeled amino acids as neuro-oncology PET tracers. Fluorine 18 fluoroethyl L-tyrosine is a PET tracer used for imaging cerebral tumours that is taken up by upregulated tumoral cells through system L amino acid transporter LAT1. The use of 18F FET in malignant brain tumour imaging is particularly useful as LAT1 is widely expressed in cancer cells and has low accumulation in normal brain tissue. It has a half-life of approximately 110 minutes and has ideal radiotracer characteristics for clinical use. Furthermore, its uptake is primarily a measure of amino acid transport rate in a tumour, which allows for differentiation and grading. The PET-MR incorporates state-of-the-art molecular imaging technology with a fully diagnostic 3T MRI combined in one imaging system. The integration of these two modalities allows for simultaneous imaging using both PET and MRI without compromising the image quality of either modality. The addition of PET, and more specifically FET-PET, with the current gold standard for neuro-oncology imaging, has the potential to overcome the limitations that MRI has in distinguishing between malignant tissue and non-malignant tissue. The aim of this research was to determine the utility of combined 18F FET PET MRI for the assessment of post-treatment changes in primary or secondary brain malignancies. The principal objective was to establish a value from quantitative analysis that can be used to differentiate between disease residual or recurrence and typical post-treatment processes. To be eligible for the trial, patients needed to have had pathologically or radiologically proven brain malignancies previously treated with either radiation therapy, gamma knife, or neurosurgery, where residual or recurrent disease was suspected. Patients needed to be physically capable to undergo a PET MRI and needed to be at least 18 years of age or older at the time of consent. Pregnancy, claustrophobia, and MRI contraindications such as pacemakers, shunts, or contrast allergies would exclude patients from recruitment. 35 patients were recruited from MDT by a team of radiation oncologists and neurosurgeons. Suitable and willing candidates were given a patient information and consent form. Once the patients were recruited, an 18F FET PET MRI was requested. On the day of the FET PET MRI, the patient would arrive to the department where the research nuclear medicine technologist would interview the patient to confirm eligibility, to cannulate, and to complete an MRI safety questionnaire. The technologist would then run through the procedure and complete any final preparations. Patients would be positioned on the PET MRI table with the head coil and then centered into the PET MRI field of view. An extension tube would be attached to the patient to allow for injection to be done outside the 5 Gauss line. PET and MRI imaging would begin in concordance with the nuclear medicine technologist injecting the radio tracer. They would then remain in the PET MRI room until the initial MRI sequence was complete. A 40-minute list mode PET acquisition would be acquired with simultaneous MRI sequences. Post-imaging, the 18F FET PET images alone were reported by a nuclear medicine trained radiologist, with the accompanying MRI sequences blind reported separately by 2 neuroradiologists. The follow-up standalone brain MRI was reported as per the centre's standard practice. For FET PET quantitative analysis, regions of interest were drawn around all suspected lesions, which were compared to a control region drawn on the thalamus on the contralateral side of the lesions or the side that had least disease involvement. The thalamus was chosen as a control region as it contains grey matter and is representative of global brain tissue. The SUV max of the lesions and control region of interest were assessed at different time points throughout the acquisition. A follow-up standalone brain MRI was acquired 2 to 3 months post-initial imaging. Some of the advanced neurological MRI sequences acquired in the initial imaging, such as tractography, perfusion, and permeability, were not performed for follow-up. The follow-up MRI was used to indicate whether disease progression was in fact present in comparison to the initial PET MRI. Lesions were determined to be malignant or benign based on anatomical tumour volume measurements and imaging characteristics. Out of the 35 recruited patients, 6 were not able to undergo follow-up imaging. That left us with a cohort of 29 patients, of which a total of 93 lesions were identified for follow-up assessment. 24 of those 93 lesions were considered positive for disease recurrence or residual on the follow-up MRI. 18 of the 24 positive lesions were reported as suspected disease on the initial imaging reports, with 13 of those being identified on both the FET, PET and initial MRI reports. 4 were identified solely on the FET, PET report, and 1 identified solely on the initial MRI report. Time activity curves based on the dynamic 18F FET PET data show that significant SUV max changes occur within the first 20 minutes, and all tissue types increase in FET uptake with time. Malignant lesions demonstrate the highest SUV max readings at all time points, with benign lesions demonstrating higher SUV max readings than that of the control tissue. For both malignant and benign lesions, the data demonstrated that larger sized lesions have a higher SUV max and smaller sized lesions have a lower SUV max for all time points. The curves also demonstrated that malignant lesions have higher SUV maxes at all time points compared to the mean SUV maxes of benign lesions. Interestingly, the smaller benign lesions measuring 10 millimeters and under had readings that were comparable to those from the control region, whereas for malignant lesions, there is a noticeable increase in SUV max size groups compared to that of the control. The collected data also demonstrates that larger lesions have higher SUV max, and this stands for all time points. The diagnostic results demonstrate that the sensitivity and accuracy of 18F FET imaging alone outperforms MRI, with 16.7% and 1.7% improvement respectively, with the MRI having a greater specificity of 85.5% compared to the 82.6% from the FET PET. However, it is important to note that these results are based on the MRI done with additional neurological sequences, like the permeability and the perfusion. These sequences are not standardly done for normal oncology brain workups and do help in ascertaining information like metabolic tumour volumes, which aid in reporting. Overall, the combined FET-PET MRI imaging demonstrates increased percentages for all diagnostic result categories. 18F FET PET MRI has demonstrated its utility for the assessment of primary or secondary brain malignancies in the post-treatment phase. From the data, we have been able to ascertain that lesions greater than 10 millimeters in size and with an SUV max of 1.65 times that of the control SUV max are indicative of disease residual or recurrence. Furthermore, lesions 10 millimeters or smaller should be considered highly suspicious for disease, where a substantial difference is seen between the SUV max and the control SUV max. Long-term patient follow-up is a study limitation of this trial, as the 5-year survival rate of brain cancer is only 22%. This highlights the aggressive nature of the disease and how early detection of residual or recurrence could play a crucial role in patient prognosis. 18F FET PET MRI has greater diagnostic value for early disease detection, allowing for swifter intervention, and also may negate the need for more invasive procedures like biopsy, which have higher risks of adverse events. Further benefits of 18F FET PET MRI include the ability to image disease process through amino acid radiolabeling and providing functional information to guide treatment options and planning. Additionally, it's a simultaneous acquisition that provides superior structural characterization and improved spatial resolution over conventional MRI and PET-CT imaging. Plus, it has the added value of incorporating MRI techniques such as contrast-enhanced imaging and tractography. In conclusion, 18F FET in conjunction with PET MRI has shown improved sensitivity, specificity, and accuracy in the detection of residual tumour and when differentiating between surgical scarring, radiation necrosis, and tumour recurrence. Based on the results of this trial, we were able to establish a threshold where a lesion with an SUV max of 1.65 times that of background tissue is indicative of disease, and anything less is considered typical post-treatment changes. Furthermore, 18F FET PET-MR imaging provides additional valuable information to assist with disease management and treatment planning, and allows for same-day imaging, saving both patient and staffing resources. From this trial, 18F FET PET-MRI not only has demonstrated its utility for the assessment of post-treatment changes in primary or secondary brain malignancies, but also suggests a place for its use in initial staging.